Welcome to another episode of Judgment Date. It's interesting that throughout this pandemic, in which we've concentrated on the medical, social, economic, and legal consequences of the pandemic, that we've been privileged to get a whole host of extraordinarily gifted, talented, and leading people in their fields to come to talk to us. And thus, I should also tell you that when it comes to the question of the pandemic itself, certain people on the sort of committee which the government has organized refused to come onto this program. I'm not quite sure why. You can draw your own inferences. By contrast, my guest today has been extremely generous with his time. He's come on before, and he really is a leading expert in all sorts of ways. And I'm referring to Professor Alex van der Heever, the Chair of Social Security Systems Administration and Management Studies at University of Witwatersrand. Alex, I'm really privileged to have you again. Thank you so much for your time. Now, thank you. I should confess that one of the reasons I was determined to have you back was I was privileged to hear you the other night talk to a small group of us. And I wanted to, and it was an extraordinary presentation. I thought more people should hear it. I appreciate that you can't go through all the details, but perhaps let me start with, when you presented to us, you indicated that the figures that are available in the public domain are totally incorrect, both in relation to deaths and in relation to infections. Now, I wonder if you could just fill us in as to what your work has indicated.
Yeah, so firstly, the first issue to understand is that the reported figures that we have it should come with a big health warning. So it's not that people are attempting to provide distorted information, but they are subject to certain caveats that are important to point out. So the first is that the mortality information that we have from regular reports largely come from facility-based reports by hospital in a parallel reporting system to, for instance, our normal reporting of deaths, which will go through the Department of Home Affairs for normal death registrations. And what one picks up as a difference between those two is a huge leap in deaths that are substantially in excess of what would have been expected if you look at the reported deaths. So the first issue is that the deaths that we are seeing are substantially underreported. And then we've got a further issue with the number of infections that are reported. So if we end up looking at the excess death information as being COVID deaths, not collateral deaths, not because, not an indirect consequence of the pandemic, but a direct consequence. If we see them as that, the natural approach to use is to then use that information, which is very hard, good, solid information, to then estimate what the number of infections probably were that generated those deaths. And when you look at that, those two together, then the excess death information suggests a substantial excess of death, and we also have a number of infections that must be way larger than the reported number of infections. And when we put that together, it gives us a different picture about the kind of local epidemic we faced in South Africa. It is substantially larger. So we're looking at potentially about 140,000 deaths, as opposed to sort of in order of 50,000 that would have been reported. So it's orders of magnitude different. And when we look at working back to reported infections, we're looking at in excess of, say, 9 million potential infections that have occurred, or higher, depending on assumptions around the infection fatality rate that you might apply to estimate the number of infections.
Could I just ask you on that, if I may, if I could just take the deaths for a moment. How is this because one looks at the excess deaths which are reported, and I think the MRC, and they don't explain them, or how can we be so certain that it's not collateral, so that it really is COVID, or reason, we put it that way?
Yeah, so firstly, the excess deaths would be based on a deviation from the projected deaths in a week in, let's say, 2020 and 2021. So based on historical mortality trends for people over the age of 1 and excluding deaths from unnatural causes. you work with a projection that provides you with a baseline. And if you then have a deviation from that baseline, then it must be because of something that changed that wasn't in the data in 2019 and 2018. So what I've done is to take that data, that deviation, which is very pronounced, and to correlate it with the reported new infection data, and to see how closely it correlates. And if it closely correlates with that data, the assumption is that it is directly caused by COVID, not indirectly caused.
Can I just ask you, for the purposes of my audience who know nothing about statistics, what would you mean by closely correlated?
So closely correlated means that it moves together with the actual epidemic trend. So if we suddenly have a rise in new infections and we have a rise in deaths, we presume that there's a relationship between the two.
Got you.
So just now, I've already indicated that there's probably an error in the number of infections that are reported. So the question would be, why would you correlate against a data set that is compromised? So the question is really how it's compromised. So I don't believe that the new infection data, the reported infection data, is compromised in the movements, in the trends. It's compromised in the quantum, the actual overall amount that is reported. So I think that the new infection data does reflect, the actual reported infection data provides a good indication of when the disease is on the rise and in decline. It's actually accurately tracking the epidemic, but not necessarily the number of people who are being infected. So that means that you can correlate the two, and if there's a close correlation, that can't be due to other causes because the relationship is so close. And I'm getting sort of 97, 98% correlations at both a national level and a provincial level. And it's important to note that at a provincial level, the trends, the actual trajectory of the epidemic is different in the Eastern Cape and the Free State from Gauteng and from the Western Cape. They actually have different trends. So if they're highly correlated at a provincial level and at a national level, the only conclusion that can be drawn is that the deaths are actually directly caused by infections. And so that then has big implications for then indicating what the scale of the epidemic is. And the correlation is extremely high, both in my estimates. I do create my own excess death trend as a check on the MRC trend and the MRC excess death projections. Both are highly correlated, although there are slight differences, in magnitude between my estimate and that of the MRC.
If we take 145,000 deaths, if you had a 1% fatality rate, that'd give you 14.5 million. What I don't know is, I mean, are we looking at sort of death figures in terms of comparative figures around the world in order to sort of get some range? How do we do that?
So we can't really, because a lot of the data that's reported in other countries is as compromised as our data. So different countries are going to have different standards. So if the UK sets up a parallel reporting system to its reported death, its normal deaths, death registrations, they might actually have a much closer match between that information and their data because they've got a very good data collection. But it's important to note that the UK, for instance, did not include the deaths in nursing homes when they did their parallel reporting. And in fact, it was the excess death analyses that revealed the gap. And so again, if you went on the UK reports, which were more accurate than ours, I would expect in terms of the parallel reporting, but still not accurate. The US is all over the place. There is no consistency in reporting on both infections and in deaths. It really is very difficult to tell, and therefore you can't totally rely on their data either. So we can't do an international comparison. Even on infection fatality rates, we would have to do very careful studies to eliminate all the mistakes in the data collection process that affect both the denominator and the numerator.
So just on that then, there have been sort of two pieces that have intrigued me. Adrian Gore from Discovery came out, I think you've probably seen it, suggesting as high as 30 million, which is literally half our population. I didn't see any basis by which they substantiated that. You may know more about it than me. but that seems much higher than even any of your maximum estimate.
Yeah, I don't know where he's getting that from, but I did check it. It would imply on my data set for my excess mortality estimates an infection fatality rate of about 0.52 to generate a 50% infection of the country as a whole. And if I do that, it produces numbers that don't even correlate properly with the blood bank information, which he's referring to as well as a kind of prevalence estimate. Others have kind of said in 0.8. Now, the importance of the infection fatality rate, just to refer to it, is that it's really a method of working back from the deaths to the number of infections. And there is no real certainty on that number anywhere in the world. So I wouldn't put my head on a block for even my number. And it's very easy to go very low. The lower the infection fatality rate, the higher the estimated number of infections. The lower the rate, the fewer. And so when somebody says, well, it's about 0.5% as an infection fatality rate, you could be way off just on the difference between 0.8 and 0.5. It has huge implications. The number is very sensitive. So I really don't believe that number. I think it's a nonsense number. I think we're probably looking at, certainly we're way higher than what's reported, but nowhere as high, in my view, as 50% of the population.
Okay, no, that would accord with my reading, but I'm not an expert. What I wanted to ask you secondly was you referred to the blood study. Now, how accurate is that one, and where and what benefit can we derive from that study?
So first of all, the key problem with the blood bank data is extrapolating it onto the national population, because it's what's often referred to as a biased sample, because it's a selective group that comes to blood banks. That's not an adequate reflection of the general population. We have seen very high infection levels of relatively high income people. Medical scheme members, in fact, constituted a very large portion of the total number of reported infections in South Africa. Whether they're white or black, and they would be in this blood bank data. What you're not necessarily getting are people living in rural areas, people in less dense populations, all sorts of areas and instances where the natural prevalence is going to be lower. So they picked up very high prevalence levels, and they pick up variations between provinces that are consistent with the excess death information. But what's difficult to do is to extrapolate their number that they get out of the blood bank data onto the entire population. So they say, on their data, they would say Eastern Cape, 63% of the population has been infected. And Free State, 46%, and KwaZulu-Natal, 52%. So those are very high numbers in those settings. I get much lower than those, but I do get that variation on the mortality side. It's consistent with that, but that's just out of the data they received, the blood that they could assess. So it's one measure of prevalence, but it is not necessarily one that you can generalize onto the South African population. So I think it's indicative of something, but it is, and it does suggest very high prevalence. But I don't think that you can translate the prevalence numbers they've got into a general population prevalence.
So just before I get on to the implications of this, can I just ask from your figures, was there a significant difference in pattern between the first wave and the second wave?
Yes, there's quite a different pattern, which is very interesting. Which implies different causes and different factors that affected the downward trajectory or the peaks of the different surges. So in the first surge, you had virtually every province had a different peak, which is interesting. And they also had a different starting point for the upward trajectory. So their peak means that they started to go into decline in different periods. And so it looked as though there was a movement of infections from one province to another as it kind of spread spatially through South Africa. In the second wave, what you see is a rise occurring in two provinces first, Western Cape and Eastern Cape, and then you see this rapid rise everywhere else. But the very interesting thing is that we have the downward trajectory, the peak basically begins in almost every single province on roughly the same date, within 3 days of each other in January. And that did not happen in the first surge. And that implies that the restrictions that were implemented in December probably had a uniform effect across the country. In other words, it targeted potentially the right things, gatherings of people in high-risk settings, so which our interventions in the first one didn't necessarily coherently target.
So would that explain why in South Africa's other countries we had a kind of rapid rise, and then we're sort of gone right down now, I suppose, waiting for our third wave, but we're in a sort of calm area. So are you suggesting that actually the measures government took had a significant contributory factor to that depression?
Yes, I think they did. But what is difficult to work out is which one had which effect. And that's where I think it's very important for us to understand that, because in the case of the general alcohol ban, which was potentially an overreach, it implicitly or indirectly targeted pubs, shebeens, areas that had effectively been behaving badly during the and drove the second surge. But it wasn't only pubs and shebeens, it was also people holding mass gatherings in which they were drinking alcohol. And so these general gatherings, which were not terribly important to the economy, but were very important to super spreading, were happening. And when they introduced two things, the alcohol ban and the more severe curfew, I think they indirectly impacted on all sorts of gatherings. So the question would be, can you be more targeted in future? Because the more targeted you are on the right thing, the less damage you do to the economy, which is a very important thing to measure, because South Africa is not really in a position to support the businesses it destroys through restrictions. So it has to actually compensate. If in the first surge, we had a restriction configuration along the lines of what we use now, we would have been able to support the businesses we closed because it wasn't everybody. But in the first surge, we closed everybody, which created an extra impossible support approach for government and destroyed its fiscal position for the next 7 years. Basically, in a month and a half, we put the South African government into fiscal crisis for about 7 years. And so there's a lot of uncertainty ahead there on its ability to support anybody that gets shut down, as well as to catalyze a stimulus for economic regrowth. So that is the difficulty. If you can shut down the right things and support the businesses that you shut down, you can keep both the economy going and you can attack the disease efficiently. And that to me is a very important formula that we really should have been thinking of from the first surge. What is the right mix?
Sorry, in other words, just to get this right, what you're saying is shebeens and pubs, apart from the mass gatherings, are clear super spreaders. If you shut them down, but you actually provide them with the resources to continue until such time as you can open up again, you can leave the rest open, you can save a massive amount of jobs, and you can depress the wave at the same time. Is that what you're really suggesting?
That's correct. So we can look very carefully in this downward trajectory at what we left open and didn't cause super spreading. We left shopping centers open. We left restaurants open. We took away the serving of alcohol. They were subject to a curfew, but they were open. So lots of things were open that we would have thought are high risk, and yet in fact we curtailed the key super spreading events. So it means that many of our restaurants, for instance, are not drivers of the epidemic if they abide by reasonable protocols. So if we shut down the right things, we can support them.
Can I then ask you, I mean, there is likely to be a third wave, I assume.
Yes. And
by opening up these things again, the pubs and the shebeens, at some point they are going to create super spreader events yet again.
Yes, so...
How do you monitor that? How do you monitor that when you know, like, okay, at this point we better shut you down and subsidize you, but we've got to close you down?
Yeah, so one of the things that we should have been able to rely on is our notification system. In other words, are we starting to see a pickup in new infections? And this is something else that's quite interesting coming out of the excess death information. is that the excess death information, which produces relatively hard results and is also tied to the date of death accurately. It knows when you died. You must provide that information. It's on your death certificate. The excess death movements actually precede the new infection information, roughly by about a week or so, which means that our deaths are being reported before our infections. And what that means, if we had to translate that, what does that mean about when we are getting the signal of a new trajectory coming up, a new surge? It means that we probably, somebody when they're getting tested is probably about a week after they've been infected, and then probably about another week, that result is getting through into the NICD and being published. And they don't publish on the day you were tested. They publish the day they received the data for some reason. And what that means when you put all of that together is that they're providing us with a picture that is 3 weeks minimum, 3 weeks ago. So we're always getting information 3 weeks late, and 3 weeks is enough for a surge to take off, for super spreading events to actually produce a massive trajectory. And if that's our signal for taking action, by the time we actually implement any kind of restrictions, we're probably 6 weeks into a massive surge, which is effectively what happened now. So that's the one. When do we get the signal? When are we flagged to intervene? Right now, I'm picking up excess death rises in, say, the Eastern Cape. And given that they precede the infections and the reported infections, it might be that we've got another worrying uptick coming from the Eastern Cape, but it's not in the other provinces yet. So the issue is really, if you see that, do we need to be targeted in our intervention? In other words, now go to identify from, it would be nice if our notifications told us that it was coming from these facilities and these areas. We're not getting that data made public. And that way they could have a targeted response. So if you had to, yeah.
One final question on this. So for example, those of us in the Western Cape, I mean, when I talk about this, a lot of people point out to me that in Khayelitsha, there was a far higher wave in the first, infection rate in the first wave than the second wave. So was this kind of geographically different in the second wave? Is that because some more people were infected in the first wave and therefore there was a slower infection rate in the second wave?
Yeah, so there was already a kind of a theory about explaining why the first surge trended down at the point that it did. And one of the questions was whether or not we had hit a kind of localized herd immunity. So we've got these general restrictions in place, and we've got vulnerable communities that don't find it very easy to socially distance and to protect themselves with non-pharmaceutical interventions. And so the epidemic rises there, but it doesn't spread to every other area, which still has very high population susceptible to infection, but because they're being protected, it doesn't take off. So these areas have the disease run through and then it stops. So that was the theory, that in fact areas like Khayelitsha and Alexandra kind of had a very severe epidemic. And in fact, some of the seroprevalence studies done in those areas strongly suggest that. They suggest very high prevalence rates. And that could imply that, in fact, they had a degree of natural immunity from natural infections that came from the first surge. Now, just note that the second surge, according to analysis which isn't completely out, was predominantly the South African variant, which implied that it was a different variant of the virus than in the first surge. And there's evidence emerging that people are being reinfected with this variant, which would suggest that people could be reinfected in those areas in the second surge, but weren't if that happened. So I'd say it's unclear at this point. And just to note that the South African variant was not being analyzed with tests. It was being, people were doing genomic analysis, which means that they were sampling the data. So it wasn't the complete population, all of our tests that were being analyzed. They just finalized the development of tests for the South African variant now, so it can be incorporated into the general reporting information, which will give us a true picture of how many people are being infected by the original wild virus and the South African variant. But if it was if the South African variant was reinfecting people, then you wouldn't have had too much protection from the first round, other than potentially protecting people from severe disease, but not from infection. I'd say we don't know enough yet, but there isn't enough data collected on reinfections in South Africa to truly analyze these particular surges. But I think that there's a very high probability that even if people get reinfected, they do have a degree of immunity that is built in. It means that it reduces the potential for severe illness and death.
So let me ask you, what does this all then tell us in relation to the implications for vaccine policy?
So firstly, it implies that if you vaccinate, you do have to vaccinate the entire population again, even if you've been infected. So there's no harm in being revaccinated. It just, it boosts your immune response. So we pretty much have to go for a kind of a herd immunity strategy in vaccinations. The second issue in the strategy is that we are going to be facing variants with a degree of uncertainty over the next 2 years.
More variants.
More variants, and not just the ones that develop here, and possibly ones that might develop in the South African context. So that implies booster shots in the vaccination strategy, probably over a number of years, a bit like flu shots. And so the question really is, so the flu at the moment, the flu shots, people will say, if you're at risk of severe disease, because you've got comorbidities and lots of high risk factors that are all identical to the COVID high risk factors, that you should get the flu shots. And in the same way, it might be that people go for revaccinations and booster shots if they're in the high risk groups 3 years from now, but not necessarily the whole population. But I would say that we're probably looking at a trajectory in which we will have probably several times in which we will be vaccinated in this case, until in which we probably won't eliminate this disease. But what we will probably do is have minimized its potential for severe disease and mortality. So we will have converted it into a version of flu.
But that's all very nice and theoretical, in the sense that all we know at this point in time is that by the end of March, we'll have 300,000 doses of vaccine. Because we don't know when the next is coming thereafter, as I understand it. Maybe I've got a completely...
I think it's very difficult to understand the vaccine acquisition program at this point, because you have a number of different statements being made about we've got so many doses that we've confirmed, but it seems to be different each time there's an announcement. The bilateral negotiation started very late in South Africa, which is a pity. And there wasn't really a coherent rollout strategy. In other words, how we're actually going to administer a vaccine when it does arrive. So we're not actually in a position to roll out generally. What we're seeing at the moment is a rollout at vaccine trial sites. These were sites in areas that were part of the Johnson & Johnson trials and various other areas that were part of vaccine trials. So they're actually set up to do vaccinations. And if you look at the current rollout, the entire private health system's frontline workers have no vaccines. It's not being rolled out for them, because this current rollout is entirely an extension of a trial. It's not actually a generalized rollout, because Johnson & Johnson doesn't have regulatory approval for a general rollout at this point. They still have to get that. So currently they only have approval for a trial. And so we do have a lot of uncertainty about the trajectory of which vaccine is arriving when, and what kind of vaccines we will deploy, even if we've got them, such as the AstraZeneca vaccine.
I mean, it is a shocking omission that, in fact, the population has been kept in the dark, and that every week the narrative shifts. But would I be right in suggesting that if we look at it now, certainly by the 31st of December last year, and perhaps even a few days thereafter, there was no acquisition strategy at all?
Yeah, apart from COVAX, and I think that was kind of the lazy way out, because you go and join an agreement, pay in some money, and then wait until June. And I think that was quite literally what the Department of Health and the Minister of Health had done, is that they had kind of sat on their hands thinking, well, that's the only game in town, and we just wait. The rest of the world, the countries that had kind of proactive governments had already begun looking at this strategy, because it really is our key strategy to get out of this mess. And it is our only way out, the vaccine strategy. So they had begun to look at the two things. One is acquisition and the other is rollout. The two are really important. There's no point in them arriving at an airport and you don't have a system of getting them reticulated into society. So what was clear by 31st of December is we had neither. So government had not engaged in any kind of bilateral negotiation to any substantive level, and only began from the 6th of January. And so largely what we're seeing now are the outcome of kind of attempts to pick up the ball late and do what we can with where we are. And at this point, a lot of the manufacturers already have made commitments on distribution. So we're largely sitting there trying to persuade vaccine manufacturers to deviate slightly from existing commitments and to get agreements from governments that have got those commitments to kind of give some leeway, to give South Africa some benefit. So we would be asking the United States, please let us have more Johnson & Johnson. Please let us have some Pfizer. In the way that we went to India and said, please let us have some AstraZeneca. And and that is a possible way out, but that's what we have to do at this stage, is we have to get people to walk back their commitments to some degree. And that can help us because we're a relatively small country. Because if we get 10 million doses here and 5 million doses here, it all adds up. But that's where we are.
But assuming we've got that, just one other question about procurement before I ask you about distribution. Is what is your attitude to the fact that the government has said it's got to be centrally procured? And I noticed Mr. Gore defending that in his statement yesterday.
Yeah, so first of all, maybe just, large parts of the private sector have to collaborate with government because government has such power over them from a regulatory perspective that they have to collaborate and be nice and polite. But Adrian Gore doesn't represent us, and he doesn't even represent Discovery Health Medical Scheme members. So he doesn't even represent industry. So the important point there is that the centralized approach is what government wants. It's not actually what any of the private sector think is sensible at this point. However, if government were very effective in reaching these deals and being key to persuading other governments to back off from arrangements, it would make sense if they were doing that. But if basically they fail in that task, we're left hanging. As South Africa is left hanging because all our eggs are in the basket of the central procurement process, of which we have very little understanding. It's not clear what's going on, and there's no transparency around it. So I think that the issue of bilateral arrangements, yeah.
No, sorry, but Adrian Gore's Adrian Gore's line, which is a point which we need to debate, is that if, for example, you allowed the private medical schemes to go off and do their own thing, we may basically just exacerbate the discrimination in South Africa between those who can afford medical aids and the rest. And so we would all get the vaccine and poor people wouldn't. I think that's the point he was trying to make. Therefore, you need to have it centralized.
Yeah, so that's where he's wrong, is that the government, if everybody agrees to abide by a rollout strategy, which is fair and equitable, that doesn't require a centralized procurement process. So procurement doesn't need to be centralized in order to have an equitable rollout. And I think that is a key consideration. I think it's very problematic when the two are assumed to be tied at the hip. They're not. Okay. So if you, for instance, allow the Western Cape to enter into a bilateral agreement and to negotiate with different companies, they could still and should still abide by a national rollout strategy. So the issue of allowing players to get ahead and create agreements, apply for licenses and move forward probably will end up with us having more vaccines available than if one player just went on it on its own. So I think that the centralized procurement is not about equity, it's meant to be about expeditious procurement. And if we don't get expeditious procurement from a centralized process, then you look at a more decentralized process. So I don't see the value of making that an imposition in exactly the same way as the national government said, you know, the best way to distribute food parcels is to do it centrally, and we'll prohibit gift of the givers and everybody else from distributing food parcels. And you have to ask, why would you do that? If it ends up with some people getting the benefit. But I agree that you do not do this and break with the equity principle in a pandemic. But procurement is a different matter.
Then one final question. I haven't got enough time to fill up all the distribution questions. Let me put something to you, which is from my very rudimentary arithmetic. So if, for example, we were able to vaccinate 50,000 people a day, which seems quite an achievement, that's 350,000 people a week, that would take 40 weeks to vaccinate 14 million, which is way off the 40 million. So number one, this is on that very rudimentary assumption, and I can't see us doing 50,000 a day, but maybe I'm wrong on that. But even if it was more, it's going to take us way into next year, even if we got the vaccines in the next couple of months. Would I be correct?
So yes, you would if we only vaccinated 50,000 a day. And the question is, what would be our upward capability? Many countries have achieved way above that. And if we were using all of our platforms effectively, that's all the pharmacies, all retail pharmacies that do the flu injections, all our general practitioner services, our private hospital services, as well as our public facilities, we've actually got a massive platform that can do a lot of vaccinating very fast. So I think that we could certainly be looking, I know that Shabir Mahdi would argue that we would be struggling at about 150,000 a day. I can't see why we shouldn't be able to do about sort of 250,000 a day, given our health infrastructure. But it does require that we have a rollout strategy. And that to me is the concern, is that we don't appear to have it. And I've seen comments from the private sector saying, you know, we don't even know what we're meant to do. Even in this initial rollout, we're frontline health workers. Nobody is even providing us with a vaccine. So you've got a whole health system standing, watching. And that's part of the problem of centralization. It's also part of the problem of having acquired vaccines.
Are you basically saying at this point in time, as far as your knowledge is concerned, we do not have the kind of sophisticated distribution system that would bear the weight of, obviously not my 50,000, but let's say 150,000 or even more? We haven't got that yet. We don't know.
I would say that we definitely have the capability to do a lot more than 50,000 a day.
Right. No, fair enough.
But we have not.
I'm asking, is there a strategy in place? If, for example, somebody said, actually, we've got a strategy, would there be something I could read which would explain exactly how we're going to do 100 or 200 upwards?
Yes, if there were, so if there were a strategy that was public, it is possible that these discussions have happened somewhere, but it is not apparent, and it's not apparent in anything that's changing on the ground. So
I suspect that would mean that the private sector would know that too. If you're going to have that on your line of argument, Discam, Clicks, the private doctors, the private hospitals, everybody's got to be on board in order for vaccination of that level of magnitude to take place. Now, if you're going to have that,
so that's correct.
Now, before we get the damn vaccines, rather than later.
So this is what I would have expected. If you had to look at how Israel proceeded, and I don't want to use Israel as the example of values, but at least of a process. They only have 6 million people, but they were. But if you look at when they started their planning, they began the process about June last year, and they already had a rollout strategy by September. So they already put together the machinery for rollout, and they had the bilateral agreements laid out. So the moment you have the clinical trials coming through, they could kickstart their process. Now, let's look at us. We should have had a complete rollout strategy in September, and we could have. There was nothing obstructing the National Department of Health, who wants to centralize all sorts of control over things. But when they centralize control and want to do everything, they actually do nothing for long periods of time and then try and explain it later. The issue is this rollout strategy and negotiation for it, if it was going to take 3 months, you want it to be the 3 months from up until September 2020. We haven't had that yet. So what happens is we're trying in a sort of a muddling through approach to kind of get stuff off the ground. And I think that one of the reasons.
Sorry, it would be helpful, would it not, for government to say, actually, Professor van der Heever, you're completely wrong. Here's the strategy. You want to inform the entire public exactly what our plan is. There's no reason why they shouldn't tell us if they had one.
Yes, and I'd be really glad if they did that.
I agree.
It'd be wonderful if they could just refute me with everything and say, here's all the detailed planning. We've got all of our ducks in a row. The moment we've got vaccines, this is how it gets to clicks. This is how it gets to Dischem. This is how it gets to Netcare and Joburg Hospital. All of that information is very, very clear. Here's the distribution mechanism. Here's how we match supply and demand and appointments. All of that is done, and this is how it will work. But I think that they're way behind on setting that up, and I think that they were quite happy that they could find a reason not to distribute AstraZeneca, because that was a general rollout. And unlike Johnson & Johnson, and the general rollout implied that they had to have everything, all their ducks in a row, and they're not in a row. And just to note a comparison is that in the AstraZeneca case, they arrived and said, we're going to send it off to the Free State for 15 days before we do anything. When Johnson & Johnson arrived 2 days ago, within a day, it's in people's arms. So you have to look at
wasn't there a different regulatory mechanism that they were seeking to apply?
He's suggesting that people didn't need to quality assure.
I don't know. I'm just saying. I'm just asking. I'm trying to find out what the reason was.
There's no logical reason. Both have regulatory approval, and okay. AstraZeneca had regulatory approval to proceed. There's no need to do a quality assurance check for 15 days. That was just a delaying tactic because they couldn't roll out. So and now the issue is, so a lot of people are saying, thank goodness we didn't have to roll out because we weren't ready. And that, I think, tells the story.
All right. I've run out of time. I want to say this, but firstly, I want to thank you for both your expertise and your candor and your willingness to inform the public, which is desperately in need of information. But perhaps what flows from yours is perhaps let me issue a challenge then to the government. Anybody in the government is listening to this who thinks that Professor van der Heever has got it wrong, that there is a serious distribution plan, which they could tell us about, it can't be a national secret, then I would invite them to come and tell us. I'd be more than happy to host them. And I'd be very delighted to host them, because that would certainly calm me and every other listener who's listened to this program down considerably. But without more ado, thank you so much, Alex. That's terrific and incredibly beneficial to everybody. Thank you.
Thank you.